Hello, class, and welcome to our lecture series on psychotic disorders. Now, we've talked about schizophrenia already, and while schizophrenia often dominates our discussions around psychosis, there are several other psychotic disorders that share features with schizophrenia that are distinct in some key ways. And so, when we explore today, we're going to be exploring some of these lesser known disorders, examining how they relate to schizophrenia spectrum and how they stand apart. Now, psychotic disorders are generally characterized by a loss of contact with reality. They manifest in many ways, such as hallucinations and delusions and disorganized thinking. And schizophrenia is the most widely studied and discussed disorder in this spectrum. But the DSM-5 TR, which is what we're in now at the time of this recording, defines a broader range of conditions that exhibit psychotic features, and some of which may overlap with the appearance of schizophrenia, but they differ in criteria and presentations. These include things like schizoaffective disorder, brief psychotic disorder, delusional disorder, and psychosis induced by substances or medical conditions. So today's lecture will begin by placing these disorders in context with schizophrenia, while they share, some key, some core symptoms such as hallucinations and delusions, and the duration, the triggers, and accompanying symptoms will often differ. So as we dive into this lecture, I want to, as always, start with a little story, and then we're going to dive into some main themes. The first theme is how we diagnose and differentiate these psychotic disorders. And my goal here is to really provide a clear understanding of how psychotic disorders beyond schizophrenia are diagnosed and distinguished from one another. Now, I want to kind of clarify something here. When I first started in this field, we didn't talk about schizophrenia. We talked about schizophrenias. There's many different types, and now we've kind of as the nosology of schizophrenia has grown and changed and been refined, we kind of put it all on a bit of a spectrum. So while I talk about schizophrenia, you can also please hear me say schizophrenias, because there is some differentiation within the spectrum of schizophrenia. Now, and what I'll try to be discussing, I'll try to keep it to the DSM-5 TR, even though I have this other history. And I want to kind of focus on, in the first theme, focus on how disorders like schizoaffective disorder and brief psychotic disorder and delusional disorder and other disorders differ from schizophrenia. And I want to give some special emphasis to the unique features of each of these disorders and their symptom presentations and how they intersect with and diverge from that broader schizophrenia spectrum. Then we'll kind of look at a little bit of the etiology and contributing factors and explore the biological, the psychological, and environmental factors that contribute to the development of psychotic disorders. And we'll examine the role of genetics and neurobiology, things like the dopamine system and the glutamate systems, as well as trauma and stress and emotion and environmental triggers like substance use. And understanding all of these multifactorial causes of psychotic disorders will help to inform our understanding of these conditions and point to opportunities for early intervention and treatment. And then finally, a little bit about treatment and prognosis. We'll look at some of the evidence-based treatment approaches and the long-term outcomes for individuals with psychotic disorders. Treatments for psychotic disorders are varied, from pharmacological interventions like antipsychotic medications to psychotherapeutic approaches, things like cognitive behavioral therapy. And we'll also discuss the challenges of treatment adherence, managed side effects, and the importance of early intervention. And prognosis will be considered in terms of factors that contribute to recovery, the concept of recovery-oriented care, and the strategies to reduce stigma and support within the community and help with community integration. The person I want to introduce you to today and tell you a little story about is Karl Jaspers from 1883 to 1969. He was born in 1883 in Oldenburg, Germany, and he died in Basel, Switzerland in 1969. He was a German-Swiss psychiatrist. He was also a bit of a philosopher who made some significant contributions to the understanding of delusional psychotic disorders. And unlike many of his contemporaries, Jaspers focused on the nature of delusions, which are a central feature of various psychotic disorders, such as delusional disorder and schizoaffective disorder, and other non-schizophrenia-related psychosis. He worked in a field called phenomenology, which is kind of the philosophical study of the subjective human experience, as well as psychopathology, which is mental illness, and the abnormal psychology, and how each of these had a profound impact on his study and diagnosis of psychotic disorders, particularly with those involving delusions. And one of Jaspers' most important contributions in psychiatry was his development of what we can call a phenomenological psychopathology, which basically just means the subjective experience of living with an abnormal psychology, and which is an approach that really emphasizes the understanding of the subjective experiences of individuals with their mental disorders. And he argued that to fully understand psychotic conditions, especially those involving delusions, psychiatrists must grasp how patients experience their own reality. And Jaspers made a distinction between primary delusions, which arise without any understandable cause and are seen as a direct result of psychosis, and secondary delusions, which are influenced by a person's mood or situation. And this little bit of a nuanced understanding of delusions helped clinicians and researchers differentiate delusional disorders from other psychotic disorders like schizophrenia, where delusions may be accompanied by more pervasive thought disturbances, hallucinations, and even the disorganized thinking that you think. And Jaspers also introduced the idea of what we can think of as the ununderstandability of primary delusions. What he argued basically was that while clinicians could empathize with or understand how secondary delusions arise from anxiety or trauma, primary delusions, which are not tied to any logical or emotional cause, remain incomprehensible in the traditional sense. And this philosophical stance helped to separate delusional disorders from mood disorders with psychotic features, or schizophrenia. And so there's a bit of a legacy with Karl Jaspers, because he laid the groundwork for modern approaches to delusional disorders and psychosis in general. He had a very rigorous philosophical approach to psychiatry, where he encouraged clinicians to dive into the lived experiences of patients with psychosis rather than simply categorize the symptoms. Jasper's work wanted to kind of humanize the people that they worked with as well. And he wrote a book in 1913, so fairly early on in his career, called General Psychopathology, that is still considered one of the most important texts in psychiatric education, because it provides a foundation for phenomenological approaches to mental illness, which can be very valuable. Now, let's take a little bit of time and just kind of explain what psychotic means. Psychosis is really a broad term used to describe, in essence, a loss of contact with reality, where individuals may experience delusions, hallucinations, and disorganized thinking. And these symptoms can cause significant distress and impair functioning in daily life. Psychotic episodes often involve a break from the shared reality that most people experience, which can manifest as false beliefs, delusions, or sensory experiences, hallucinations that are not present for others. Now, I want to kind of just outline a few of the psychotic disorders that we see within the DSM. First off, we have something called schizoaffective disorder, which is basically a combination of psychotic symptoms with some mood disturbances. Then we have brief psychotic disorder, which is a short-term psychotic episode triggered normally by stress or trauma. And we have delusional disorder, which is persistent delusions without other major psychotic symptoms. Then there is substance or medication-induced psychotic disorder, and this is when a psychosis is triggered from the use or the withdrawal from substances. There's psychotic disorder due to another medical condition, and this is psychosis resulting from underlying medical issues. And then we have something called catatonia, which is basically a syndrome that can occur in various psychotic and mood disorders, and is characterized by abnormal movement or behavior. And each of these disorders shares some characteristics with schizophrenia, but they still differ in some important ways, such as the duration of symptoms, the presence of mood disturbances, or the triggering factors. So when we talk about prevalence and epidemiology of psychotic disorders globally, psychotic disorders are relatively rare compared to other mental health conditions. Globally, it's estimated that about 1 in 100 people will experience some form of psychotic disorder during their lifetime. Schizoaffective disorder, for example, has a lower prevalence than schizophrenia, while brief psychotic disorder is even less common. And delusional disorder, though rare, tends to be more stable and enduring over time. So factors such as genetics and socioeconomic status and environmental stressors can influence the prevalence of these disorders in different populations. So early detection and intervention really seem to be critical in managing psychotic disorders, and research shows that early treatment can significantly improve outcomes and reduce the severity of psychotic episodes and enhance long-term recovery. So early intervention programs focused on identifying at-risk individuals, providing immediate care, and preventing the progression of symptoms are very valuable, because left untreated, psychotic disorders can become chronic, and they can really impair a person's ability to function and increase the risk of co-occurring conditions such as depression or substance use disorders and social isolation. Now, I want to take a little bit of time and try to differentiate schizoaffective disorder from schizophrenia and mood disorders, and provide a bit of an in-depth understanding of these features and how it intersects with both psychosis and mood disturbances. Schizoaffective disorder basically is a condition characterized by a combination of psychotic symptoms such as delusions and hallucinations and significant mood disturbances, either depressive or manic episodes. So according to the DSM-5, the key diagnostic criteria for a schizoaffective disorder include things like, first off, a major mood episode, either depression or manic. And this is concurrent with what we call criterion A of schizophrenia, which is delusions, hallucinations, disorganized speech, or other psychotic symptoms. So you have these two things happening at the same time. And the psychotic symptoms must occur for at least 2 weeks in the absence of a major mood episode as well. And then the mood symptom must be present for the majority of the duration of the illness. So schizoaffective disorder can often be really challenging to diagnose because it overlaps with both schizophrenia and bipolar or major depressive disorder. So it really does require some careful evaluation and timing and duration of symptoms. And one of the hallmark features of schizoaffective disorder is the presence of these psychotic symptoms, and occurring both during and outside of the mood episodes. So unlike bipolar disorder with psychotic features, where psychosis only occurs during the mood episodes, schizoaffective disorder requires that psychotic symptoms persist for at least 2 weeks, independently of mood disturbances. And this distinction is crucial in differentiating the two disorders. So here I just want to kind of clarify a little bit the different types, because you can have bipolar type or depressive type. So schizoaffective disorder can be characterized into these two types. The bipolar type is just what you would expect. It involves episodes of mania and sometimes major depressive episodes. And psychotic symptoms occur both during and outside of mood episodes. And then you have the depressive type, which involves only major depressive episodes with no history of manic episodes. And both, and the distinction here is that but psychotic symptoms still occur outside of the depressive periods. So understanding these types is really essential for effective diagnosis and treatment, as they can influence the choice of medications and the therapeutic interventions that are used. So I just want to compare how this compares to bipolar with psychotic features, which is distinct clearly from schizoaffective disorder. So here's where it gets a little bit tricky. Bipolar with psychotic features has psychosis is only present during the mood episode, either the mania or depression. So once the mood episode resolves, the psychotic symptoms typically do as well. And that's different from schizoaffective disorder, where psychotic symptoms are present during the mood episodes, but they persist while the individual is not experiencing significant mood disturbances. And this persistence of psychotic symptoms, independent of mood episodes, is the key difference. So schizoaffective disorder exists at the intersection of psychosis and mood disorders, making it a very complex condition to diagnose and treat. I also want to explore a couple of other disorders. One is brief psychotic disorder and delusional disorder, and highlight their distinctive features and how they differ from other psychotic disorders. So, brief psychotic disorder is really characterized by the sudden onset of psychotic symptoms such as delusions, hallucinations, disorganized speech, or grossly disorganized or catatonic behaviors. And according to the DSM-5 TR, the key diagnostic criterion includes things like the duration of the episode that lasts for at least 1 day, but less than 1 month, with eventual full return to pre-episode functioning. So it's brief, but it does occur. It's not just an hour, though. It's for at least a day. The disturbance is not better explained by major depressive disorder or bipolar disorder with psychotic features or another psychotic disorder like schizophrenia, nor is it due to substances or medical conditions, as far as we can tell, other medical conditions. And sometimes there can be a potential trigger, because brief psychotic disorder, it's been seen, can often be triggered by stress or trauma or significant life changes, and it tends to occur more frequently in individuals with pre-existing vulnerabilities to psychosis. So this disorder is notably different from other psychotic disorders in that its duration is very short, and individuals typically regain their previous level of functioning once the episode resolves. Now, there's a famous confirmed case of brief psychotic disorder, and that's that of an American singer and actress. Back in the day when I was young, Marie Osmond was super famous. And back, over 25 years ago now, in 1999, Marie Osmond experienced a well-documented episode of brief psychotic disorder following the birth of her son, Matthew. She had been open about her mental health struggles during that time and attributing the condition to postpartum hormonal changes and emotional stress and exhaustion. And Osmond recounted experiencing intense mood swings and confusion and hallucinations, and she was apparently diagnosed with brief psychotic disorder, which is characterized by a sudden onset of psychotic symptoms such as delusions, hallucinations, and disorganized speech or behavior, which typically last for less than a month. And I think that Marie Osmond's willingness to share her experience really brought some attention to the disorder and helped to destigmatize mental health issues, particularly in the context of postpartum psychosis. And I think I have seen other cases of famous people experience this, though they haven't documented it or admitted to it, so I don't want to kind of bring it up. But her case remains one of the more high profile and still confirmed instances that we have of brief psychotic disorder. Then there is delusional disorder, and this is where you have persistent delusions in the absence of other psychotic symptoms. And delusional disorder is characterized primarily by the presence of one or more delusions lasting for at least 1 month. However, unlike schizophrenia or schizoaffective disorder, other psychotic symptoms such as hallucinations or disorganized speech are either absent or very limited. So there are some key features of delusional disorder that we need to include. So delusions are typically non-bizarre. So, for example, they're being followed or poisoned, but they can also be bizarre at times, although typically they're not. And bizarre, I would have something like aliens kidnapped me and implanted a device in my body to track me. And the individual's behavior here is generally not obviously odd or behavior outside of the delusions, and their ability to function in daily life may not be significantly impaired apart from the delusional belief. So there are different types of delusions. This delusional disorder can be classified based on the type of delusion. You can have a persecutory delusions, which are basically beliefs that someone is conspiring against you or they're persecuting you. You can have grandiose delusions, where you believe that you have exceptional abilities, or you're world famous, or you are the person that influences governments. You can have somatic delusions, where you believe that something is wrong with your body, like you have diseases that you don't have. You can have erotomanic beliefs, things like beliefs that another person, usually someone super famous, is in love with you. Or jealous delusions. These are beliefs that one's partner is being unfaithful and there's no evidence of it. And so individuals with delusional disorders often maintain a relatively normal life outside of their delusion, which is a significant differentiator from other psychotic disorders that typically affect overall functioning more broadly. Now, there's a well-documented case of delusional disorder that involves the famous author Mary Todd Lincoln, the wife of President Abraham Lincoln. And following the death of her husband and the tragic loss of 3 of her 4 sons, Mary Todd Lincoln began to exhibit symptoms of delusional thinking, particularly in the later years of her life. She suffered from persecutory delusions, believing that people were trying to harm her or steal from her, and also from somatic delusions, where she believed that she was physically ill with conditions that had no medical basis. And these delusions became so severe that her only surviving son, Robert Todd Lincoln, sought some legal action to have her committed to a psychiatric institution in 1875. Mary Todd Lincoln's case, I think, is a historical example of delusional disorder, where the individual maintains persistent, non-bizarre, so she's, and in her case, it was that she was being persecuted or that she had these physical illnesses, without the broader disorganization of thoughts or hallucinations that we see in schizophrenia. So her struggles were highly publicized at the time, and her case really kind of remains one of the most famous examples of delusional disorder in a prominent figure. Now, I also want to take a little bit of time and talk about substance or medication-induced psychotic disorder. Because according to the DSM-5, substance and medication-induced psychotic disorder is diagnosed when psychotic symptoms such as delusions or hallucinations occur during or shortly after substance intoxication, or during or shortly after withdrawal or exposure to medication. And the key diagnostic criteria here includes the presence of delusions or hallucinations, and evidence from history and from physical examination or laboratory findings that the symptoms develop during or soon after substance intoxication, withdrawal, or exposure to medication known to induce psychosis. And the psychotic disturbance is not better explained by a primary psychotic disorder, like schizophrenia. And it does not occur exclusively during the course of delirium. And the disturbance causes significant distress or impairment in social and occupational or other areas of functioning. So common disturbances that induce psychosis. You can have alcohol-induced psychosis. It is more likely to occur during very severe intoxication or withdrawal, where you get what's called DT or delirium tremens, where your GABA and glutamate systems are thrown out of whack. And the hallucinations and delusions are common during these episodes. Then also with stimulants like cocaine, methamphetamine, or amphetamine are known to, or really well known actually, to induce psychosis, especially with chronic use. Users here often experience paranoid delusions and hallucinations, particularly tactile, such as feeling bugs crawling under their skin. I had one fellow, I took him to the hospital, and he had pulled out he looked like he'd been bitten all the way down his arm. And he insisted that there were bugs coming out of his arm. And it just turned out that he had been pulling on his skin so much that it looked like they'd been biting. Then there's hallucinogens like LSD, psilocybin, and penicillin that induce psychotic symptoms, visual and auditory hallucinations during their intoxication. Cannabis can do this as well, particularly high doses of cannabis or prolonged use of cannabis, particularly in individuals with a predisposition to psychosis. This can induce psychotic episodes, and psychosis is more likely to occur during or immediately following intoxication. And sometimes other substances, inhalants or synthetic cannabinoids, and even some prescription medications like steroids have been associated with psychotic symptoms. And symptoms can also be during intoxication. And what kind of the difference between intoxication and withdrawal here? Because the timing of psychotic symptoms is essential in differentiating substance and medication-induced psychotic disorder from other primary psychotic disorders. So during intoxication, psychosis will often occur when individuals are actively under the influence of substances like stimulants or hallucinogens or alcohol. And these symptoms are typically temporary and resolve as the substance is metabolized. But sometimes it's during the withdrawal period. So psychotic symptoms can also emerge during the withdrawal phase, particularly in substances like alcohol or benzodiazepines. And this type of psychosis can last longer and may be more severe depending on the substance and the individual history of use. So there's a famous and well-documented case of substance-induced psychotic disorder in an individual by the name of Brian Wilson. You might have heard of Brian Wilson. He's an old-school rocker, and he's the lead singer and basically the primary songwriter of a band known as the Beach Boys. You might, if you're not old like me, you might not have known of the Beach Boys, but in the 1960s and 70s, Wilson was a heavy drug user, particularly things like amphetamine and LSD, and that triggered a severe mental health crisis that included episodes of psychosis. And Wilson began experiencing hallucinations and paranoid delusions and erratic behavior, all characteristic with substance-induced psychotic disorder. And his mental health deteriorated to the point where he became very reclusive, and he isolated from the band and actually spent years confined to his home, often in a state of confusion or paranoia. And his substance abuse appears to have been the primary catalyst of these psychotic episodes. And after receiving treatment and reducing his drug use, Wilson's mental health slowly improved. though he continued to struggle with residual mental health challenges. So I just want you to be aware that, this can impact anybody, even the most famous of us. So how do we rule out primary psychotic disorders? Because it's really one of the most critical aspects of diagnosing substance or medication-induced psychotic disorder is ruling out the possibility of a primary psychotic disorder like schizophrenia, or to a lesser extent, schizoaffective disorder. And to do this, clinicians need to carefully evaluate whether the psychotic symptoms are directly linked to substance use or withdrawal. And if the psychosis persists long after the substance has cleared out of the body, the primary psychotic disorder may be more likely. So it's important to do a medical or substance use history in your diagnosis. So having a thorough medical history and an assessment of substance use, obviously here, is very essential in diagnosing this disorder. So clinicians need to determine whether the individual has been using substances known to cause psychosis, or whether the timing of symptoms aligns with intoxication or withdrawal phases. So in essence, substance and medication-induced psychotic disorder really highlights how substances and medications can lead to psychosis, with symptoms often resolving once the substance is out of the individual's body. Now, I want to move on and talk a little bit about psychotic disorders due to another medical condition. Because the DSM does allow for that, to be diagnosed with psychotic symptoms such as hallucinations or delusions as part of a medical condition. So, in this case, there needs to be some prominent delusions or hallucinations that are present. There is evidence that history, physical examination, or laboratory findings that the disturbance is the direct pathophysiological consequence of another medical condition, that this disturbance is not better explained by another mental disorder, and that the disturbance does not occur exclusively during the course of delirium. So the thing to kind of be clear here is that psychotic disorders due to another medical condition is distinct from primary psychotic disorders like schizophrenia. So some medical conditions that can cause psychosis are things like neurological disorders, epilepsy, brain tumors, traumatic brain injury, Parkinson's disease, Alzheimer's, Huntington's disease, infections from encephalitis or like HIV/AIDS can cause inflammation. Syphilis, in its late stage, infects the neurons, so you get neurosyphilis, and that can cause profound psychotic symptoms. You can have metabolic disorders like hypoglycemia or electrolyte imbalances or liver failure or renal failure that can cause disturbances and confusion and hallucinations and bizarre behavior in people. And you can also have autoimmune disorders like lupus and multiple sclerosis that can affect the central nervous system and sometimes trigger psychotic symptoms. So there are a lot of things that can impact upon a person. So we need to kind of be aware of that and try to rule some of those things out as well. I want to kind of just talk a little bit about catatonia and what catatonia is, because catatonia is a psychomotor syndrome that's characterized by abnormalities in movement and behavior. And it's a broad definition that can have lots of different subsets. So you can have stupor, which is no psychomotor activity, and a person basically is not actively relating to the environment. You can have what's called catalepsy, which is a passive induction of a posture held against gravity, so you can kind of move someone. You can have what's called waxy flexibility, which is there's some slight resistance to positioning by an examiner, but you can still move a person. There's mutism, where there's little or no verbal response. There's what's called negativism, which is the opposition or no response to external stimuli. There's posturing, which is spontaneous and active maintenance of a posture against gravity. There's just bizarre mannerisms, so exaggerated actions or behaviors. There's grimacing, which is involuntary facial expressions. There's agitation, which are unprovoked physical movements that aren't influenced by external stimuli. There's echolalia, which is the mimicking of someone's speech. So you say something, someone kind of says it back in a mimicking way. And then there's echopraxia, which is mimicking another person's movement. So there's lots of different features of catatonia, and it can be from extreme mobility and unresponsiveness, which would be stupor, to excessive movement and agitation. And we can have we can have catatonia in a lot of different things. It can be in schizophrenia. Catatonia is most often linked to schizophrenia, but only a minority of individuals with schizophrenia actually experience catatonia. And they tend to manifest in things like mutism or posturing or negativism. But it can happen in mood disorders, particularly in bipolar disorder or severe depression. And it can happen in some other medical conditions like neurological disorders like encephalitis or stroke, or in a metabolic imbalance. So there's a lot of things that can impact it. What tends to help in some cases is benzodiazepines, so something like lorazepam. Typically is the first line of treatment for catatonia, and they tend to have a rapid effect on alleviating the symptoms. In some severe cases, electroconvulsive therapy has been shown to be fairly effective in relieving catatonia. So there are some other parts to this. Now, I want to kind of take a little bit of time, because we've spent a lot of time here just covering the nosology, and we want to kind of get into what causes these things. And so we'll go through some of these things. And I want you to understand that in the etiology of psychotic disorders, we're thinking in terms of the biological, the psychological, and the environmental. So when we look at this, there are a couple of things that we need to be mindful of. First off, we can think of genetics, because there is a strong evidence that genetics plays a fairly significant role in the development of psychotic disorders. Individuals with a first-degree relative, like a parent or sibling, who has schizophrenia or another psychotic disorder, are at an increased risk of developing a similar condition. And research into genome-wide association studies has identified multiple genes associated with an increased susceptibility to psychosis, particularly genes involving a number of systems. First off, the dopaminergic system, as well as the glutaminergic system and the GABAergic neurotransmission. So it's no surprise then that when we look at neurotransmitters and we see that dysregulation or imbalance of dopamine and glutamate and serotonin has been strongly linked to the onset of psychotic symptoms. So dopamine hypothesis is one of the biggest ones, and it's one of the most prominent theories, and this suggests that overactivity of dopamine in certain areas of the brain, like what we call the mesolimbic system, contributes to hallucinations and delusions, while underactivity in other regions, such as the prefrontal cortex, is associated with negative symptoms like lack of motivation or the blunted affect. So we also see brain structure abnormalities. So in neuroimaging studies, we see that there can be, with people with psychotic disorders, they typically will have some structural abnormalities in the brain, like enlarged ventricles, so which indicates that there's lots of brain tissue, or reduced gray matter, which is kind of the thing that kind of keeps you who you are, in the prefrontal cortex, and the hippocampal abnormalities. And these are all common in people with schizophrenia and other psychotic disorders. So these structural changes are thought to contribute to some of the cognitive and perceptual distortions that we see in psychosis. Of course, there is stress and trauma. Stressful events like traumas or abuse or the sudden loss of a loved one can trigger or exacerbate psychotic symptoms. So the diathos stress model suggests that while genetics and biology provide a predisposition, psychosocial stressors can trigger the onset of the symptoms. So like childhood trauma in particular has been identified as a significant risk factor for developing psychosis in later life. Also, having a lower socioeconomic status, such as living in poverty or unemployment or social isolation, has been associated with an increased risk of developing psychotic disorders. And then there are environmental factors, like being around people that use substances and using substances yourself. Behavioral factors, like using cannabis or stimulants or hallucinogens, can trigger or worsen psychotic disorders. Prenatal exposure to certain infections or stress or infections. Some research has been linked to just the flu, and your mother has the flu and you're in the womb. That can increase your risk. As well as birth complications like lack of oxygen, hypoxia, can cause some troubles too. Now, there are some good treatments, and the treatments have been getting better and better over time. Antipsychotic medications, which are the primary treatment for psychotic disorders, involve the use of what we call antipsychotic medications. And there are different generations that we can have. So we can think in terms of first generation antipsychotics, also known as typical antipsychotics. And these drugs like chlorpromazine or haloperidol are primarily, what they do is they primarily target the dopamine receptors, particularly D2 receptors. And these reduce symptoms like delusions and hallucinations while they affect other symptoms. So the problem is that they're a little too broad, and so they impact other parts of the brain. And one of the parts of the brain that they impact is something called extrapyramidal neurons, which have then extrapyramidal side effects. Now, extrapyramidal neurons are really involved in muscle movement. So you end up with something called tardive dyskinesia, where you have these random involuntary facial movements, or you end up with muscle stiffness or tremors because these extrapyramidal neurons are being damaged. So first generation antipsychotics, while an incredible game changer in allowing a lot of people that were living in hospitals because they couldn't function and couldn't stay in touch with reality, they could go back home and live a life, they did have some significant side effects. So we've moved on to second generation antipsychotics, things like risperidone and olanzapine. And these target both dopamine and serotonin receptors. And they're generally preferred because they don't have the same motor-related side effects, but because things like serotonin also regulate your digestive tract and all sorts of other things, people do find that they gain weight when they take these, or they have other metabolic syndrome, or they just feel tired. They feel kind of like they're being sedated in some way. So there can be some side effects with these as well. We also are getting to the place where we have long-acting injectables, antipsychotics like paliperidone and palmitate, and these are administered every few weeks, and so you're not missing your daily dosage. You get it, and it lasts in your body for a long time. And so it significantly reduces the risk of relapse. So basically, while medications are great, we are still working on managing some of the side effects with these things. And then of course, there is other psychological treatments that we should be engaging into with people. So like cognitive behavioral therapy to help to modify delusional beliefs and help people cope with hallucinations. It doesn't cure psychosis, but it can kind of help to adjust some of the false thinking that gets tied in with this, as well as some family therapy, because there are typically some bizarre communication styles and some bizarre ideas that end up disrupting the family, and the family can end up actually exacerbating the problem a little bit. So that can be, because there's been a lot of research. Actually, family therapy came about because some psychiatrists thought at one time that certain family types and certain ways of communicating in family caused schizophrenia. It's called the schizophrenogenic family. And so there is some interplay that needs to be dealt with there as well. Now, overall, what's the prognosis for someone with psychotic disorders? If there is early treatment, that is really critical for improving long-term outcomes for individuals with psychotic disorders. It also depends upon the severity and type of the disorder. For example, brief psychotic disorder tends to have a more favorable outcome and prognosis, as many individuals experience a full recovery within a month. Now, in contrast, conditions like schizoaffective disorder or delusional disorder may involve more chronic symptom patterns, though individuals with these disorders may still experience periods of remission. So having a good social support, including family and friends and mental health professionals, has been shown to improve the outcomes of people. So it just naturally improves your life. And having some insights into the illness. Individuals who have a greater understanding of their condition and insight into their symptoms tend to have better outcomes. So when you have lack of insight, what we call sorry, I got tongue-tied there. Anosognia. It is when you have lack of insight. It is, which is common in many psychotic disorders, because they don't think they have a problem, particularly in schizophrenia. That can be a significant barrier to treatment and to adherence. So one of the important things is to surround the person with recovery-oriented care. Allow the person to have a sense of purpose and control and meaning in life, but still adhere to their treatment plan. These, particularly in longer term, like things like schizoaffective disorder, it is a long-term disorder. So let's close out with a review of some key terms. So what is schizoaffective disorder? Well, we can kind of think of it as a mental health condition that's really characterized by a combination of symptoms of schizophrenia. So we have the hallucinations and the delusions, and the mood disorder symptoms like depression or manic episodes. So it's those two things kind of smushed together. But it is distinguished by the persistence of psychotic symptoms even outside of the mood episodes. And that's the key there. What is a delusion? Now, we've talked about a delusion. We should probably really clarify it here. A delusion really is a false belief that is strongly held despite evidence to the contrary. Delusions can be persecutory, grandiose, somatic, or involve other themes. And they are common symptoms in psychotic disorders such as schizophrenia and schizoaffective disorder and delusional disorder. There are hallucinations, which are sensory perceptions that occur in the absence of external stimuli. And they can involve any of the senses, with auditory hallucinations, so hearing voices, being the most common in psychotic disorders. And hallucinations are a hallmark of conditions like schizophrenia and schizoaffective disorder. And finally, we come down to our quiz question. Which of the following is distinguished, or what are the distinguishing features of delusional disorder compared to other psychotic disorders? And it's right there in the name, where you have the presence of delusions without other psychotic symptoms. So you don't have disorganized thinking, you don't have hallucinations. You just have the delusions. If you just have the delusions, then it would clearly be delusional disorder. Okay, so I hope you enjoyed this lecture, and hope you were able to kind of locate your understanding of other psychotic disorders in relation to schizophrenia or the schizophrenia spectrum. And I will see you next week. You take care. Bye-bye.